We're going to see acute cholecystitis. This could be calculus cholecystitis or acalculous cholecystitis. Acute cholecystitis is the inflammation of the gallbladder due to prolonged blockage in the case of calculus cholecystitis, or in critically ill patients like severe infections, could be cytomegalovirus infection, or in patients with a underlying disease like diabetes mellitus or HIV infected patients, burn patients, trauma patients. This can lead to acalculous acute cholecystitis, in which the reason of the inflammation of the gallbladder is infection, ischemia, or cholestasis. So anyway, in each case, we have the prolonged inflammation of the gallbladder that leads to the edema around the gallbladder here, edema, enlargement of the gallbladder wall, and this is prone to rupture. So this is an emergency. We need to do cholecystectomy. Emergency cholecystectomy if we see this emphysematous gallbladder or perforation. We need to look for this inflammation. The gallbladder can also undergo ischemia and then perforate. The ischemia is because the gallbladder is getting enlarged and then compresses the veins and then the arteries. The treatment is antibiotic when we suspect the acute cholecystitis. While we do the imaging for diagnosis, we need to give antibiotics, most commonly a second or third generation cephalosporin. And in case we see this emphysematous gallbladder or the perforation of the gallbladder, then we do the cholecystectomy, emergency cholecystectomy. We try to do it by laparoscopy, but if don't, would be surgical cholecystectomy. And in the case the patient is too ill to undergo the cholecystectomy, then we can put a cholestomy tube in which we are connecting the gallbladder to an external bag. And now the diagnosis. The diagnosis is we will look this for this inflammation with an ultrasound. If the ultrasound is equivocal, then we do the HIRA. HIRA is hepatobiliary immunodiacetic acid scan, in which we mark or we inject technetium, mark technetium 99, and then we see if the gallbladder is visualized 1 hour later. If we don't see the visualization of the gallbladder, then the patient has this acute cholecystitis. Sometimes on the ultrasound we can see the enlargement or thick wall of the gallbladder, the sometimes gallstones, if there are more than one that is locked here, because the reason for which the patient has this inflammation edema of the gallbladder is because there is a stone obstructing the cystic duct. Additionally, we could see pericholestatic fluid. So a pericholestatic fluid plus enlargement of the wall in the gallbladder is the diagnosis of the acute cholecystitis. The presentation would be right upper quadrant pain, nausea, vomiting. In the labs, we would see leukocytosis. Maybe the patient has irradiation of the pain to the right shoulder, fever, nausea, vomiting, and the first test that we will do in physical examination is the Murphy sign. In Murphy sign, we will press on the right upper quadrant, pushing upward while the patient is in inspiration, and if we see that the respiration breaks, that is positive for Murphy sign and is very suggestive of acute cholecystitis.